Thank you for joining us today. I'm so excited to get to have this conversation with you. I know so many people are struggling, I think on both sides of the endometriosis. Number one, maybe not receiving a diagnosis. I know that, it's like 10 years until most women find out that they have endometriosis. But then also once you get that diagnosis, really struggling with the available treatment options. So I'm so excited to get to talk to you today about your perspective on those things and see if we can connect women with more evidence-based resources, which is, I know, what you and I both care a lot about.
Yes, thank you so much for having me, Dr. Harper. This is exciting.
Well, I think so too. Okay, awesome. Well, I know a lot about you, but for those who are watching who don't know, can you just share with us a little bit about who you are, what you do, what your practice is focused on, and why you love doing it?
Sure. Yeah, so my name is Allyson Shrikhande. I'm a physiatrist and the co-founder of Pelvic Rehabilitation Medicine. And physiatrists, most people don't know what we are, so we're rehab docs, so we're non-operative MD and DOs who really focus on the muscles, nerves, and joints of the pelvis. And we're really rehabilitating things, so retraining, as well as kind of resetting, retraining, and we're really into function. So we talk a lot about return to quality of life, function, so a lot of talk about intercourse, bladder, bowels, exercise, sleep. These are all things that we really focus on improving in our patients, and of course pain. So we do treat pelvic pain as well, and that is an important part of quality of life and function. So yeah, so that's what we do, and that's what we do at Pelvic Rehabilitation Medicine.
I love that. Okay, so I know you'll have offices kind of all over, right? So where, if people are watching and they're interested in that, where are your offices located?
So sure, yeah. So we're in 13 different cities right now, 8 different states. We're in New York City, we're in Great Neck, Long Island, and Scarsdale, New York, and we're in Englewood, New Jersey, as well as Florham Park, New Jersey. And we're also in Coral Gables, Miami, Florida, as well as West Palm Beach, Florida. And we're in outside of Detroit, Michigan, and Birmingham, Michigan. We're in Atlanta, Georgia. We're in Dallas, Texas, and as well as Houston, Texas. We're in Washington, D.C., and we're also in Chicago, Illinois.
Amazing. Well, y'all are definitely putting your stamp down, and sorry to make you just like list off all of those. I don't know but you definitely just handled it with grace. And yes, the Dallas office is literally like probably a mile from where I am right now. So super close to my house. And we're so glad to have you in this community because we always need more resources for patients with the issues that y'all help us with. Both, and I know that we've talked about this before, but I think it's so important when you're dealing with complex issues like pelvic pain, like endometriosis, like, if people are having other issues that y'all help with, that we really address that in a multidisciplinary way. So maybe it's a gynecologist and a physiatrist and a sex therapist and a pelvic floor PT, like all the people, right? And we can, come together to really offer patients that holistic care that they deserve. So I love having y'all in the community and being able to, send people your way.
I cannot agree more. It definitely takes a village, and that's the best way, is that interdisciplinary, multimodal treatment where we all just work together, and it works wonders for our patients.
Yeah, that's amazing. Okay, so how have you seen, like when people come to you, what are they struggling with when it comes to endometriosis? What are some complaints that women might have who are struggling? And really it could be like if they know that they have endometriosis or if they don't know, kind of on both sides of that.
Yeah, no, definitely. So as we focus on the pelvis at Pelvic Rehabilitation Medicine, so we're really treating that sling. So the majority of our complaints are lower abdominal pelvic pain and then bowel, bladder, intercourse issues. So that's what people come to. Sometimes it's just one, sometimes it's just bladder, sometimes it's all three. And so that's really what we see and treat. So therefore, because of that, that's why we see a lot of endometriosis, right? Because those are really the common chief complaints of endo. So therefore we see a lot of it, and the data that we're collecting and analyzing, it's really almost 70% of our patients of reproductive age do have a history of endometriosis. So we do see quite a bit of it. I'd say the most common chief complaint we get is pain around intercourse, either during intercourse or soreness post. Is super common. It can be superficial or deep. And we see a lot of bladder, urgency, frequency, sensation of UTI that never went away, which is also super common in our patients and endometriosis. And then a lot of bowel. So constipation, straining. Sometimes there's some discomfort around the bowel movement or soreness post, a lot of bloating, abdominal kind of GI, lower abdominal pain and bloating. I'd say the first stop a lot of our endometriosis patients end up making is actually to GI doctors. That's the most common, that complaint of the bloating and constipation and abdominal pain.
Interesting. And so do y'all also see these patients, and could you intervene or help with menstrual pain as well?
Yep, we do. We're treating that whole endometriosis complex, and that cyclical nature, right? That menstrual pain is common. However, given that delayed diagnosis with endo, at this point, the data says 6.7 years. A lot of times, by the time they get to us, it was cyclical at first, but then it becomes more kind of often, less cyclical, more of a once a week to however each individual patient presents. But that cyclical nature can come and go depending on how long it's been there.
Got it. And is that due, so just because this is not my area of expertise, but I am interested. So over time, the pain of endometriosis starts cyclical, and then do those pain, receptors get upregulated, and that's why the pain is more frequent, or what's going on there? Why is it more frequent the longer they have pain?
Yeah, that's correct. They start to go into that chronic pelvic pain syndrome complex. Okay. And the connection really of endometriosis with what we do is multifactorial. The main reasons are, number one, when endometriosis is present in that pelvis, the pelvic musculature does go into that spastic guarding state, and then it essentially squeezes the nerves, which then get a little irritated and inflamed, which contributes to that chronic pain, pelvic pain kind of complex. And then also endometriosis itself is a pro-inflammatory state. So wherever it is, it will stimulate that neurogenic inflammation, all the inflammation around those pelvic nerves as well. So those are kind of the two main reasons. It can directly invade nerves, but that's not very common.
Okay. Very interesting. So when we think about endometriosis, and there's so much frustration, I think, in just women in general and women's health amongst all of us who care for patients with endometriosis, how long it takes to get these patients diagnosed and what's going on there. So why do you think that historically this is not something that's been addressed, and we haven't spent a lot of money on researching and finding, medications or treatments for, and why do you think that people are misdiagnosed, or it takes so long to get them diagnosed? What do you think is going on?
Dr. Harper, I ask myself that all the time. No, I mean, one is it's a silent disease process. So so that's challenging, right? And because we really don't have a proper diagnostic other than the gold standard currently is a surgery, right? A diagnostic. Right. Laparoscopic surgery. So I think that's the number one reason that it can be a challenge. So I do hope the NIH continues to put more research money really to finding a diagnostic, and I think the geneticists that are on our clinical advisory board for pelvic rehabilitation medicine, Drs. Gregerson and Metz, are doing fantastic work through the Rose trial to really try to find a diagnostic through analyzing the menstrual effluent. So that's number one. The diagnostic's a big issue. And number two, I think that we could do a better job of educating our medical students, and in residency, I know myself in residency, we didn't really talk about it or gain much exposure to endometriosis. So I think those two areas could be improved, and raising awareness just among healthcare professionals for sure is huge. So I think if we improve our education of awareness starting from medical school, that would really help. Another is the complex nature of endometriosis itself, right? The definition, it's endometrial-like cells found outside of the uterus, but really they can be found in many places, right?
Right.
and where they go really affects kind of the patient's presentation and symptoms. So the symptoms can be all over the map. So sometimes it's a lot of bladder, sometimes a lot of bowel, sometimes it's purely that cyclical pain with the menstrual cycle. So I think that it's a bit tricky that way, and I think that is another layer of challenge to really getting to an earlier diagnosis with our patient population. And lastly, I think it's the complex nature of the pelvis itself, because it has so many organ systems and it's such a tiny place, right? So, so there's a lot going on there. So I think that also can, and they talk to one another and upregulate one another. So I think that can also contribute to kind of muddying that diagnosis for endo. So those are the reasons I do think as to why we're here today in 2021 still. But I really do hope. So if anyone out there has any desire or to do research through the NIH and really find a diagnostic, that would be such a game changer internationally, really.
Totally. Yeah. And I think there is one more aspect, which is like that this is a disease that the main criteria for getting someone to listen is a woman talking about pain. Right. And I think traditionally that's just totally dismissed as, in society and medicine and whatever. That's just not something that's been taken seriously. And so when that's the primary complaint combined with all of these other intricacies that we've talked about, man, we have a lot of work to do for women with endometriosis for now and for all the women that are coming in the future.
I cannot agree more. I really think it's really up to, the patients to really, really understand and raise awareness amongst each other. And yeah, I completely agree and make sure that you're heard, because it's really important that your voice is heard and listened to.
Absolutely. And if that's not happening right now, then it's time to find someone who will. So if you feel like you're in it's interesting to me because I have conversations all the time with women who will go to their healthcare provider with a complaint and not feel heard, but continue to go back to them. And I just really would encourage people to find their right fit. You know what I mean? If someone's not listening to you, then it's time to find someone that will listen to you for sure. And there are people who care passionately about these issues. So, okay. So we were talking a little bit ago about like gold standard diagnostic for endometriosis. And nobody's happy about this. Patients aren't happy about this. Doctors aren't happy about this. Nobody's happy that we have to literally take a camera, do a surgery, and look into the belly and see endometriosis lesions with our eyeballs, which means that they're pretty significant, right? If we can see them, because they don't start out where we can see them with our eyeballs. So, whenever we're thinking about diagnosis of endometriosis for a patient, are there any signs or symptoms that y'all observe in patients that could help lead to that diagnosis in a patient that's not previously been diagnosed? Or what findings might suggest that a patient has endometriosis on exam for a physiatrist?
Yeah, that's a lot of it's history, really taking a good history, I think, for our patients, but things, onset, even if it started 15 years, 10, 15 years ago, or you remember, did it start around the menstrual cycle? Was there any correlation, or is it pain before around? So that's important. Family histories, family history of even hysterectomy. A lot of times they won't know endometriosis, but they may say, my mom or my aunt did have a hysterectomy for I don't know why. So some sort of family history of any surgery or endometriosis. History of autoimmune. If you have autoimmune hypothyroid, we see a lot of autoimmune in endo. Any history of infertility is important, right? Because they correlate. So I do think a lot of it is teasing out a good history and trying to see the underlying cause. And from exam, for us, I mean, as physiatrists, we really are looking at the muscles, nerves, and joints. So looking at that, hypertonic pelvic floor, that upregulation of the peripheral nerves, which you would almost always see. I think the data is like 70 to 80% of endometriosis patients would have that. So that is one thing. And then, the mobility of the pelvis internally. Important. And then we would, do a vaginal and rectal exam too, because sometimes the endo could be more posterior if you're thinking that. So those are things that we would do, but we always would have a gynecologist on board as well who sees and treats endometriosis if we have a suspicion. And like I said, we see so much of it given the chief complaints that we see and treat at PRM.
Right. Okay. And so then if a patient comes to you who knows that she has endometriosis and perhaps she's on hormonal therapy or perhaps, and maybe these are different protocols for y'all, but perhaps she's had surgical intervention to remove the endometriosis, whatever the current situation may be, how does what I might do, which could be surgery or medication that could, be taken a variety of different ways, differ from what a physiatrist might do to help a patient with endometriosis?
Yeah, that's a great question. So as physiatrists, we are really treating that upregulation of the central nervous system. So we're treating the central sensitization that happens with endometriosis, and we're calming down the peripheral nerves as well that are inflamed, and we're calming down that hypertonic pelvic floor musculature. So that would be our role in endometriosis. Right. And then, of course, taking that holistic view, working always with pelvic floor physical therapy, because as physiatrists, we're extensions of physical therapists, working closely with the pelvic floor PT, as well as talking about nutrition with our patients, as well as exercise, sleep, that sort of thing. And then we would work closely with OBGYN. You would help us manage any hormonal issues with endo, as well as any surgical approach. So an excision surgery, if needed, would be the surgery of choice. And then, we can work with patients pre or post operatively.
Okay. And whenever, just for people who are watching who aren't familiar with the language, like when you're talking about the nerves, both centrally and locally, that just means, so like you would examine the pelvis, find the nerves that are in the pelvic floor, and then what would happen? Like how do you treat them?
Yeah, so I mean, classically, patients would try a course of physical therapy first, and if it wasn't enough and they needed more, we work with PT and us. And what we're doing is an outpatient protocol that's external and ultrasound guided. Patients go on with their day right away, but conceptually, what we're trying to do is calm down and reset those hyperactive nerves. It's like rebooting a computer. So we're trying to chill them out and reboot them. And we're also trying to release that spastic pelvic floor with our ultrasound protocol. We're trying to open up, create space, and release that spastic chronic guarding.
Yeah. Okay, cool. And I think it's really helpful to think about really all health care and just really all health complaints in this holistic way that you've described. So I love that y'all talk to your patients too about nutrition and sleep and exercise. What are some of the basic recommendations or tenets for patients with endometriosis in those areas that y'all talk to them about?
Yeah, so if there is a lot of bladder symptoms, we talk about the IC diet, interstitial cystitis diet. So removing caffeine, alcohol, acidic foods overall can help. Lots of water. Increasing water seems counterintuitive because you're a lot of times peeing a lot, but increasing your water intake is helpful. And then with endometriosis specifically, a diet high in greens, so broccoli or kale, can help kind of modulate that excess estrogen in your body, and estrogen can help promote endometriosis growth. So that is one thing we talk about with our endo patients, increasing the greens. And then bowels are I'd say that's one of the most common chief complaints is bowels and endo. So a lot of times we'll maybe add some magnesium citrate in the morning to help, again, increase bowel fluids, as well as the squatty potty. We think is fantastic for nutrition, to really relax that pelvic floor and help you have a bowel movement. And then for exercise, restorative yoga is huge. It's calming down the central nervous system, that whole sympathetic parasympathetic response with a lot of the breathing techniques that are built in with the restorative yoga. But it's also opening up that pelvis at the same time, just creating space and letting blood flow to the nerves. And then in addition, it really does strengthen. It helps the nerves and the muscles talk to one another. So there's support, because it is important to have support for exercise for your organs and your joints, right? They all need support. So it is important to get the nerves and the muscles firing and in coordination together. So that restorative yoga, Your Pace Yoga by Dusty and Miller is fantastic. Adrian's yoga on YouTube is also very good. That whole restorative yoga for the pelvic floor, but it's nice because it's doing a lot without kind of asking a patient to do 10 things. It's all really in that one program.
That's awesome.
The one thing, if a patient does have hypermobility, which we are seeing a lot in endometriosis patients and then chronic pelvic pain patients in general, we stay away from yoga, just the breathing and a little more of a Pilates if they're hypermobile. So you would want to be evaluated first.
Okay. And so for patients who are like, what in the world does that mean? Is there a way for a patient to know if she might have hypermobility to like stay away from those things?
Yeah, I mean, we call it loosey-goosey joints,
Yeah.
so super flexible. But overall, you can be evaluated by come on in or PM&R or
Right.
physical therapy, if you're really wondering. But it's
Yes.
goosey joints.
Okay, very cool. And so how long does a typical endometriosis patient stay in your care at your practice? Like, what does that treatment protocol look like? Is it years or months or weeks, or how does that look?
Yeah, I mean, that's a great question. Again, it does depend on the severity of the patient. But classically, we meet a patient, it's a 3-month protocol from walking in our door to being finished. And then you follow up in another 3 months though, usually after, but it's overall a 3-month protocol. You see us once a week for 6 weeks, but you usually and then you'll see your physical therapist for the entire 3 months though. So for us, it's about 6 weeks, and then concomitantly, you'll see the physical therapist. So it's about 3 months overall because it's a functional restorative approach, right? It's increasing blood flow, decreasing inflammation, and really letting the nerves heal themselves and then getting your nerves and muscles firing. So it's that functional restorative approach that we're working on.
Amazing. Okay. And so we know where y'all are located, but how can people find you? Do they need a referral from their doctors, or can they just say, hey, I have endometriosis and pelvic pain. Like, I'd love to find out more. Like, how does that process work?
Yeah, no, you don't need a referral. Pelvicrehabilitation.com. You can check out our website, see our locations. You can request an appointment through the website, or you can call our phone number on the website, reach out through social media. Really, there's multiple ways, but once you're on the website, you can just make an appointment right there.
Okay, amazing. And then what would you recommend for people who are in places in the country that don't have access to pelvic physiatry? Like, how can they sort of do some of the things that we've talked about or access some of those things if they're not close to y'all in proximity?
That's a great question. I do feel the restorative yoga programs are a great place to start.
Okay.
And you could see if there's a pelvic floor physical therapist near you locally as well, are the 2 places that really I would start. And then go from there. And if not, you can call. We see patients from out of town all the time, so happy to chat on the phone before you come to see if you would want to see if we could potentially there.
Yeah.
So we do.
Okay, amazing. And then quickly, if you will, just review, because I said it at the beginning, but I'm not the person to really say it. What are some of the other common conditions besides endometriosis that y'all see frequently in your practice? And if I'm remembering correctly, y'all see both men and women. Is that correct?
We see women and men. It's about 70% women and 30% men. So we see some postpartum issues, any postpartum dysfunction, pelvic pain, fibroids, PCOS, adenomyosis, vulvodynia, vaginismus. For the men, a lot of we see chronic prostatitis was our most kind of common chief complaint, where they have discomfort around intercourse and urination. And then we'll see pudendal neuralgia issues, rectal pain after any sort of surgery or insult to the pelvis, coccydynia, pubic symphysis dysfunction, SI joint dysfunction, really anything that can go on in the pelvis from that kind of non-operative standpoint.
Got it. So if you've got pain in your pelvis, no matter what, then that sounds like it could be a good place to go. Does that seem like the tagline?
That's the tagline.
Okay, perfect. Well, anything else that we needed to cover today that we didn't talk about, Dr. Shrikhande?
No, thank you, Dr. Harper. I don't have anything else. This has been great. Thanks for all you do, all your information, and I really love following everything you're doing. So thank you for all your work.
No, and congrats on all of your work. And I'm so excited to conceptually build this, army of people who really care about women's health, women's pelvic floor, women's pain, and really arm doctors and therapists and everyone who works in this field with the information that y'all are around, that we can all work together in conjunction and really, advance and enhance outcomes for our patients, that we work so much better together than any of us do apart. And I think that that's the message, is to kind of make sure that we're all lining up those, referrals for our patients so that we can get them optimized as best we can.
Yeah, I completely agree. That is the key. And I forgot to mention behavioral health, but that's important. And we do have Dr. Alex Millspaugh in-house, who's wonderful and just amazing at really calming down the central nervous system and helping kind of that mindfulness-based approach is just really important for our patients. So yeah, that's been huge for us.
I love that. Yes. And definitely along the same lines of it takes a village, and that's really how healthcare is meant to be in the first place. So I'm sure if we could start over, Allyson, we would do a better job of how healthcare was built, but we can do our best with what we've got. And this is part of that. So thanks so much for spending time with us today and sharing with us what you know about endometriosis and how we can help our patients and each other better. So thank you so much.
Thank you, Dr. Harper. Talk to you later.
I'll see you soon.